สวัสดีค่ะ Good morning everyone. My name is Tawisa Maenpaen.
My name is Sukitta Kitjao.
And my name is Nithinath Ratchatapokin.
Today we would like to present our project. Does the global rating scale correlate with standard clinical outcomes in chronic individual with stroke? Let's begin.
Firstly, I will talk about introduction. A few different functions are impaired by stroke, the most common cause of disability. Multiple functional impairments following stroke may occur separately or combined, including the motor function, perception, cognition, vision, emotion, communication, and mental health. The long-term impact could be determined by the initial stroke lesion and the extent of subsequent recovery. Rehabilitation, especially physiotherapy or PT interventions, play a major role in post-stroke care, and the prevalence of stroke-related burden is expected to increase over the decades. Clearly, PT interventions aim to enhance different domains of the International Classification of Functioning Disability and Health, or ICF model, such as body, activities, participation, personal factors, and environmental factors. Management of individual with stroke needs to focus on motor and functional recovery or responsiveness in the context of both impairment and functional outcomes. Responsiveness identified by a combination of PT evaluation and individual perception of improvement. A number of well-accepted stroke assessment scales have been developed for use in worldwide clinical settings, such as the Stroke Impact Scale, Full Measure Assessment, Berg Balance Score, Modified Ranking Scale, Full Motor Function Test, Actual Research Arm Test, 10-meter walk test, and 6-minute walk test, all of which have been used as a reference standard or external criterion of change in individual with stroke. Functional outcome measures are essential in stroke rehabilitation. However, health-related quality of life measures are increasingly used to assess the status of individuals with stroke. The Stroke Impact Scale is recommended and is widely used to identify patient needs within rehabilitation intervention programs. In addition, the Global Rating of Change Scales, or GROC, is a frequently used outcome measure to allow the self-report direct perceptions of improvement and has been used as an anchor method to determine if clinically important changes have occurred. The GROC has been the alternative outcome for the patients with shoulder pain and neck pain in previous studies. Due to its ease of use and administration, the GROC is designed to quantify patient improvements or deterioration over time. It is usually used either to determine the effects of an intervention or to document the clinical course of a condition. GROC items are constructed to ask individuals to rate changes in their current health status with a recall memory of the previous time point and then score the change between that time point and their current status. The magnitude of this difference is then scored as a numerical value or on a visual analog scale. The GRC has been advocated as an outcome measure to improve the applicability of information from clinical trial to clinical practice. However, to date, there is little evidence showing the validity and the use of GROC in individuals with stroke. It may come from the questionable ability of individuals with stroke to accurately recall and score previous health status, which underpins the principal criticism of GROC scale. The GROC could be useful to determine if clinically important changes are reached within clinical trials in individuals with stroke. It is imperative to know if interventions offer a meaningful improvement in individuals with stroke and whether individuals would choose to receive the same treatment again. In addition, clinical outcomes judged by patient self-evaluation and physiotherapists for responsiveness and discrimination of high and low disability in the context of functional recovery have not yet been confirmed. To determine if a clinically meaningful change has been achieved, the comparison of standard stroke assessments and the GROC may be a useful approach in this population.
The objective, the purpose of this study were to compare the SIS and clinical outcomes consist of the modified ranking scale, Barter index, Full Measure Assessment, Berg Balance Scale, and gauge speed between baseline and after PT treatment. and to investigate the correlation between the GROC with the SIS and clinical outcomes in individuals with chronic stroke. Material and methods. Study design. After G-power calculation, 55 participants were included in this study. Each participant received a physical therapy treatment for 1 hour session twice a week by an experienced neurological physiotherapist for 12 weeks. The inclusion criteria were presenting with a chronic stroke, age over 20 years, and other information listed. Exclusion criteria were for mobility with severe systemic illness and other information listed. Procedure. For consistency of clinical outcomes, physiotherapists and participant self-assessments were conducted in parallel. The stroke impact scale 3.0 and other clinical outcomes were recorded at baseline in the first week and after 12 weeks of physical therapy treatment. In present study, used the Thai SIS 3.0 for this assessment, which was translated from the original English SIS. The SIS 3.0 consists of 59 self-report assessment items relating to stroke outcome and was used to assess health-related quality of life. The SIS consists of 9 domains: strength, hand function, mobility, physical and instrumental activity of daily living, memory and thinking, communication, emotion, and social participation, where higher scores indicate a better health-related quality of life. For the last domain of the Thai SIS, participants were asked to rate their improvements from 0 to 100. The Global Rating of Change Score is a self-assessment of perceptions which use an 11-point Likert scale. A GOC score of 0 was considered as unchanged, and GROC score of +1, +2, +3, +4, and +5 represents as minimal, moderate, and large improvements. In contrast, GROC score of -1, -2, -3, -4, and -5 indicate the degree of perceived deterioration. Statistical analysis. The data distribution was tested using the Shapiro-Wilk test for almost all of the variables. The data were found to be not normally distributed. Therefore, non-parametric analyses were used. The Wilcoxon silent test was used to compare the variables between the baseline and after 12 weeks of physical therapy treatment. In addition, we explore the correlation between each domain of the SIS and the other clinical outcomes. All correlations were performed using the Spearman's length correlation coefficient.
Result and discussion. Let's talk about a result. In Table 1, demographics of the participants, we have 44 participants that include 26 male and 18 females with a median age of 54 years and a median time since stroke onset of 3.05 years. 24 participants had hemiparesis affecting their right side and 20 participants affecting their left side. In Table 2 is about comparison of stroke impact scale in each domain and clinical outcome at baseline and 12 weeks. Significant differences were seen between baseline and after 12 weeks of physical therapy treatment for the SIS score in the domain of strength, emotion, ADL, mobility, social participation, and global recovery. And in Table 3, it's about the correlation between the global rating of change scale and each domain of stroke impact scale. The Spearman ranks correlation coefficients reveal fair correlations between the GROC score with the changes in 3 of the domains of the SIS that include emotion domain, mobility domain, and global recovery. In addition, in Table 4, about the correlation between the global rating of change scale and other clinical outcomes, the CROC show no correlation with any changes in the other clinical outcome. In discussion, this significant difference were only seen in all the SAS questionnaire domains, with the exception of communication, consistent with previous literature. The SAS and other clinical measurements taken may not be associated with functional improvements. In previous studies have found that the women who survive stroke have less favorable outcomes than their male counterparts and more likely to have physical impairments and limitations in their ADL. Post-stroke depression and social participation may affect functional recovery, cognitive, and function in individuals with stroke. The CROCs show a fair degree of correlation with a change score of SAS with significant correlation between CROC and three domains of the SAS that include emotion domain, mobility, and global recovery. The CROC score show a group clinical improvement between the baseline and after the physical therapy treatment, which were in agreement with the group changes in strength, emotion, ADL, mobility, social participation, and global recovery domains of the SAS. The CROC show no correlation with any changes in the other clinical outcome that may resulting from participants who have difficulty recalling their initial status when reporting the change of ability on the CROC scale. However, in our population who are individuals with chronic stroke, it appeared that they were able to accurately report the change in emotional, mobility, and global recovery on the CROC, as there was some degree of correlation. In a further work, should consider the ability of patients to accurately recall and score a previous health state, which is one of the principal criticisms of CROC scales. Further work is also needed to determine the bestseller question in individual with stroke and the confounding factor. In conclusion, comparison between baseline and after treatment shows significant improvement in some domains of the SAS, which was accompanied by a clinically important change in the grouped CRC score. There was a fair correlation between the CRC and the SAS. Therefore, the CROC scale could be applied to suit the needs of physiotherapists or clinicians when time and difficulty in other methods of assessment exist. Thank you so much. If anyone has any question, please don't hesitate to ask.
Okay, thank you, presenters. Nice work. So, anyone have any questions? Please. In the chat, we have another questions from Ajahn Pimuk. How many chronic stroke patients did you include in this study?
Okay, we have 55 participants were interested in the study, but 11 participants dropped out due to 11 participants withdrew from intervention and 2 participants could not complete the questionnaires. So 44 participants were left in current analysis.
All right.
Excuse me, I have a question. Can you please go back to table 2, please? I'd like to ask you about your opinion, because from the SIS domain, they show the improvement of strength. I will talk about the physical stuff like strength, ADL mobility, like this. And then when we look at the focal measure scale or work balance scale at gait speed, we couldn't see the improvement. So is there any reason why you find the improvement when you use the SIS to evaluate, but you couldn't get any improvement when you use another assessment?
What the question again? Sorry.
So
Yeah, we found the improvement in SIS, but we not
yes,
found in other measurements.
yes. I
Yeah,
want to know.
what question?
Yeah, what's your opinion
Oh,
about
okay.
the assessment tool that you used in this study?
Student, you want to answer?
Mm.
Okay, I will answer and in the chat also. SIS domain is the answer by the participant, and GROC is answered by participant, and all another measurements is measured by the physiotherapist. So it may have any confounding factor about the self-assessment and another assessment, and we found it's not improvement in the same way. Then we think the GROC is need to combine with another test. It can't use be only one test for measure the patient.
Thank you.
Thank you for your question. It's a good question.
Okay, thank you, presenters. So I think it is time's over. So thank you for our presenter again. And so if anyone have more questions about this research, please